The other topic which we are going to discuss is parasympatholytics. So what are these parasympatholytics? So these are the drugs we can say which antagonize the action of acetylcholine. So acetylcholine is one of the neurotransmitter in the cholinergic system, or else we can say parasympathetic nervous system. So the drugs which antagonize the action of parasympathetic stimulation are called as anticholinergic drugs. And if you see, there are some poisoning, organophosphorus compounds. So these are the compounds which also shows anticholinergic actions under some poisoning conditions. And apart from that, what does this anticholinergic or as parasympatholytics do? So they block the action of acetylcholine either directly or indirectly. So what does this mean? So these drugs either block the release of the acetylcholine from the synaptic nace, or else they block the binding of acetylcholine to the particular receptors, that is cholinergic receptors. So that is how they are showing the parasympatholytic activity. And these especially, the blockade of this acetylcholine towards the muscarinic receptors is more clinically preferred than nicotinic receptors. Nicotinic antagonists. So these are the antagonists, or we can say these are the category of parasympatholytic drugs which antagonize the action of acetylcholine which is binding to the nicotinic receptor. So this cholinergic receptors, as we have discussed, cholinergic receptors are of two types, muscarinic as well as nicotinic. So the acetylcholine will bind to both muscarinic as well as nicotinic receptors, but the actions which are exerted on blockade of these receptors is different. So these nicotinic receptor antagonists, they block the binding of the acetylcholine towards the nicotinic receptors and shows their action. And atropine is one of the drug which is used as a prototype of this parasympatholytic. So what does this mean? Atropine, we can say it is a sample, or else we can say it is an early material, or else we can say early drug which is showing the parasympatholytic activity. And these parasympatholytic drugs, mostly they are selective towards muscarinic receptors when compared to the nicotinic receptors. Let us see the classification of this parasympatholytic drugs, or else we can say cholinergic blockers. So these anticholinergic drugs or cholinergic blockers are divided into two types, that is anti-muscarinic as well as anti-nicotinic. So because these cholinergic receptors are of two types, muscarinic as well as nicotinic. So the drugs which antagonize the action of muscarinic receptors are called anti-muscarinic, and the drugs which antagonize the action of nicotinic receptors are called anti-nicotinic drugs. And these anti-muscarinic drugs are further classified as natural as well as synthetic drugs. And these anti-nicotinic drugs are further classified as ganglionic blockers and neuromuscular blockers. Let us see the anti-muscarinic drugs. So the anti-muscarinic drugs are classified as natural and synthetic. So the drugs which come under this natural anti-muscarinics are atropine, scopolamine and hyoscine. As well as synthetic anti-muscarinic drugs are homotropin, benzotropin, pyrazipine, tropicamide, isopropamide and benzoxane. So these are the benzoxane. So these are the anti-muscarinic drugs which are used clinically. There are other drugs apart from these anti-muscarinic and anti-nicotinic drugs, like cholinesterase reactivator. So acetylcholinesterase. So this is one of the very important enzyme which is useful in the metabolism of acetylcholine. So cholinesterase reactivators. So what does they do? They metabolize the acetylcholine and thereby they prevent the release of the acetylcholine, or else we can say they prevent the reuptake of the acetylcholine, whereby the acetylcholine release is inhibited. So the drugs which come under this category are prolidoxamine and obidoxamine. The natural alkaloids. So the natural alkaloids of anti-muscarinic drugs are atropine and hyoscine, and there are semi-synthetic derivatives also like homotropin, atropine methionnitrate, hyoscine butyl bromide and ipratropium bromide, and there are synthetic compounds like cyclopentolate and tropicamide. So these are mainly used in mydriasis. There are anti-secretory as well as antispasmodic drugs also. Like these anti-secretory or antispasmodic drugs are further classified as quaternary compounds like propanthyline, oxyphenonium, clidium, bipenzolate methyl bromide, isopropamide glycopyrrolate, and tertiary amines like dicyclomine, oxybutylene, flavoxate, pyrazipine, and telenzapine. So what are the classifications which we are discussing? This is like another classification of the drugs. So mainly these are antimuscarinic and anti-nicotinic, but based on the actions which they show, the classification of the drugs is based on like this. The anti-Parkinsonism, the drugs, or else we can say the anticholinergic drugs which show anti-Parkinsonism effect are trihexyphenidyl, procyclidine, piperidine, and benzotropine. And the other drugs, or else we can say the other drugs which are showing anticholinergic actions apart from their major actions are like tricyclic antidepressants. So these are the drugs which are used in depression, as well as they show anticholinergic effect, and phenothiazines, antihistaminics, and disopyramide. So this classification is based on the activity of the drugs as anticholinergics, as well as apart from these they are having other effects also. Let us see the muscarinic receptor antagonists or anti-muscarinic drugs. So the anti-muscarinic drugs are natural and synthetic, and apart from that, these classification is categorized based on the affinity of the drug towards the receptor. So these are muscarinic drugs are of 5 types: M1, M2, M3, M4, and M5. But M1, M3, and M5 have secretory, or as we can say stimulatory effect, as well as M2 and M4 have inhibitory effect. And M1, M3, M5 are of one category, and M2 and M4 are of other category. So, but here M1, M2, and M3 class drugs are clinically used rather than M4 and M5, because those are not clinically reported yet. So the M1 receptor antagonists are pyrazipine, telenzapine, dicyclomine, and trihexyphenidyl. And the M2 receptor antagonists are galamine and methotrexate. And the M3 receptor antagonists are darifenacin, solifenacin, oxybutylene, and tolterodine. So let us see the drugs individually. So here we are first comparing the natural alkaloids, or else we can say the naturally occurring anti-muscarinic drugs. So the naturally occurring drugs are atropine, scopolamine, or hyoscine. So hyoscine is also called scopolamine. So here what are the chief sources? As we said, these are the plant sources. So what are the plant sources they are obtained from? Atropine is obtained from the plant called Atropa belladonna, and hyoscine is obtained from Hyoscyamus niger. So these are the two plant derivative sources of these anti-muscarinic drugs. And these atropine is containing an alkaloid ester of tropine. I mean, in the sense these drugs are containing alkaloids. So atropine contain tropine alkaloids, as well as hyoscine contains scopine alkaloids, where if you see, these both alkaloids are basic in nature. But the peculiar characteristic of this scopine alkaloids are they are having oxygen bridge at C6 and C7 carbon atoms. So at the C6 and C7 carbon atom bridge, there is an oxygen atom attached to those carbon atoms. And if you see the effects, so the CNS effect of these drugs are atropine. If you see, at low as well as higher doses, it causes excitation only. But the stage of excitation differs based on the dose. At low doses, it causes mild excitation, as well as at high doses, it causes strong excitation. If we see hyoscine, it shows the action called as depressant. I mean, it causes amnesia, fatigue, as well as depression, and in higher doses it causes excitation of CNS. And if we see the anticholinergic properties, if we compare the anticholinergic property, atropine has more effective action on heart, bronchial muscle, as well as intestine, whereas hyoscine has more effect on eye and secretory glands. So these both drugs, anti-muscarinic drugs, also exert their action based on the location of the receptors also. As this atropine is very effective on heart as well as intestine and bronchial muscle, whereas hyoscine is very effective on eye and secretory glands. Whereas the duration of action of these drugs are atropine is having longer duration of action and hyoscine is having shorter duration of action. The other, or else we can say the other plant alkaloids, or else the other plant sources of these anti-muscarinic drugs are the Atropa belladonna, where atropine is obtained from, and this Atropa belladonna is also called as deadly nightshade, and Brugmansia species. So these are one of the species which produce the alkaloids, or else we can say they contain the alkaloids which are having antimuscarinic effects. And Datura species, Hyoscyamus niger, as well as Mandragora officinarum. So these are few of the plant sources where these contain alkaloids which are having antimuscarinic effect. Let us see the pharmacological actions of these antimuscarinic drugs. So these antimuscarinic drugs all have the same action by inhibiting the release of acetylcholine. So they inhibit the release of the acetylcholine from the synaptic nerves. So these exert the pharmacological actions, like the pharmacological actions differs based on the selectivity towards the receptor as well as the location of the receptor also. So in CNS, so what does it do? What does it do? Especially as we are saying atropine is a prototype drug or a sample drug, most of the antimuscarinic drugs mimic the action of this atropine only. So let us take atropine as an example and show the effects. So this atropine, it shows the stimulant effect on CNS. We saw it shows the excitatory effect. So in atropine, at low doses it causes mild excitation effect, and in higher doses it causes strong excitation effect. So excitation is nothing but stimulant effect only. So even all other drugs also show stimulant effect on the CNS, but if the action of these antimuscarinic drugs lasts for a longer period of time, then it may cause sedation. And scopolamine. So scopolamine is nothing but hyoscine. It is having very mild central effects. So we saw that the scopolamine, it shows the depression effect, as well as in higher doses it causes excitatory effect. So this action of scopolamine on CNS is based on the dose. And apart from that, in higher doses or in toxic doses, this scopolamine will leads to in higher doses this scopolamine is leading to the excitation effect, that is called if we see the dose of atropine as well as if we compare the dose of atropine and hyoscine, at low doses of atropine, the effect which is shown by the atropine at low dose is shown by the scopolamine at higher doses. So that is the reason in higher doses of scopolamine and in less doses of scopolamine, it is showing actions of agitation, excitation and hallucinations. Let us see the effects on Parkinson's disease. So what happens in Parkinson's disease? We saw few of the antimuscarinic drugs which are used as anticholinergics in anti-Parkinson's effect. So here in Parkinson's disease, there will be we can say there will be decreased dopamine. So when there is any dopamine, there will be reduced dopamine levels in the brain, then it leads to Parkinson's disease. So here if there is any relative cholinergic excess, or else we can say the cholinergic stimulation is shown in excessive amount, it causes deficiency of dopaminergic activity, thereby it leading to the we can say it is showing the effect in the Parkinson's disease. So here what happens is that if these anticholinergic drugs are administered to the Parkinson's patient, or else we can say patient who is suffering from Parkinson's disease, because of the stimulation of the cholinergic system, the dopaminergic activity is reduced. So if dopamine activity is reduced, then definitely the person will recover from the Parkinson's condition. So that is the reason how these drugs are administered in Parkinson's. And apart from that, this in Parkinson's disease, the antimuscarinic receptors are given in combination with dopamine precursors. So here we can see the schematic diagram where the dopamine is released from the synaptic nace or the synaptic vesicles, and it is binding to the dopaminergic receptors and exerts its action. So if dopamine levels are increased, then it causes depression, or else we can say CNS relaxation. Instead of stimulation of the CNS central nervous system, there will be relaxation of the CNS nervous system, or else we can say depression of the CNS nervous system. So what are the other consequences, other pharmacological effects of these antimuscarinic drugs? So they causes vestibular disturbances. So if there is any disturbances in the eye or ear, or else we can say if there is any disturbances in the vestibular regions, then these antimuscarinic drugs are given. For example, if you see this motion sickness, So if a person is having, or else we can say if a person is having a phobia or a sickness or during takeoff of flight or landing of flight or during traveling, that is called motion sickness. So in these conditions, hyoscine or scopolamine is mostly recommended, and it is also as I told you, scopolamine, L-scopolamine, that is levo form of scopolamine is more effective in this motion sickness. What are the pharmacological actions of these antimuscarinic drugs in eye, or else what happens in eye? Here you can see the flow chart. Here the muscarinic cholinergic stimulation. So in the eye, what are the muscarinic receptors which are present? When they get stimulated, then it causes the constriction of the pupil. So when the constriction of the pupil will takes place, then there will be blockade by topical atropine. Here, if the constriction of pupil will takes place, then the vision won't be in a proper way. That is one of the side effect of these anticholinergic drugs. So these anticholinergic drugs have common side effects of dry mouth and blurred vision. So this blurred vision is because of the constriction of the pupil of the eye. Thereby it leads to a condition called as mydriasis. The other effect on eye is like weakening of contraction of the ciliary muscles. So cycloplegia. So cycloplegia is a condition where there occurs paralysis of the ciliary muscles. So these ciliary muscles in the eye aid in the proper vision. So if the paralysis of the ciliary muscles takes place, then the vision will be in blurred form, or else we can say the vision will be improper, and there will be loss of accommodation, as well as the vision won't be, the person cannot see the objects which are very close to his vision, and it also causes decrease in the lacrimal secretions. So the secretions which are secreted out of the lacrimal glands which are present in the eye, the secretions will be reduced, thereby it leading to dry eyes. What are the effects on cardiovascular system? So if these anticholinergic drugs or antimuscarinic drugs, they causes blockade of vagal flowing. So here to the heart or to the cardiovascular system, the vagus nerve supplies the nerves, or else we can say the vagus nerve will vagus nerve supply is there in the cardiovascular system. So this vagus nerve is emerging out of the parasympathetic nervous system. So the blockade of this vagus nerve takes place because of this antimuscarinic drugs, and thereby it causes relative tachycardia, as well as it in the initial doses, or else we can say in the slow doses, it may lead to bradycardia condition also. Respiratory system. So what happens to the respiratory system if these anticholinergic drugs are given? So in the respiratory system, we can see there occurs the we can say the stimulation of these smooth muscles, or else we can say the stimulation of smooth muscles and secretory glands which are present in the respiratory system can be altered, because to the respiratory system there will be vagal innervation. The vagus nerve innervations will be there, or else we can say the vagus nerve supply will be there in the respiratory system. So we saw that there will be decreased vagus nerve stimulation because of this antimuscarinic drugs. So because of that, there occurs constriction of the bronchial smooth muscles, as well as there will be decreased secretions in the respiratory waves, and thereby it leads to the, if this blockade takes place, then it leads to bronchodilation and there will be decreased secretion. And here it is mostly, because of this bronchodilatory effect which is shown by these antimuscarinic drugs, so these drugs are preferred to give in asthma as well as in COPD, that is coronary obstructive pulmonary disorder, and it is also used prior to inhalant anesthetics, thereby to decrease the secretions in the trachea. So before giving surgery, or before giving this inhalant anesthetics, so if we are giving inhalant anesthetics to the patients, these drugs are mostly recommended because they decrease the secretions of the trachea. Let us see the effects of antimuscarinic or else anticholinergic drugs on GIT. So these antimuscarinic drugs, they show or else we can say they show marked effects on salivary secretions. In the sense, they decrease the salivary secretions. The secretions which are produced by the salivary glands will be decreased, and that is the reason it causes dry mouth, and it causes gastric secretions. gastric acid secretions will be altered. So the secretions which are even produced in the gastrointestinal tract will be reduced. Because of these antimuscarinic drugs, whatever the secretions which are produced in the body can be altered. We can say the secretions can be reduced. And the drugs like pyranzapine and telanzapine, they causes decreased gastric acid secretion but when compared to other drugs, these drugs are having fewer side effects. The other actions on this GIT are, it causes, we can say the M1 as well as M3 receptors are present on this gastrointestinal tract. But the drugs which are having, or as we can say the antimuscarinic drugs which are there, they are having higher affinity towards the M1 receptor rather than the M3 receptors or other muscarinic receptors. So because of that, the motility of the GIT will be decreased. So because of these affinity towards the M1 receptors, usually the stimulation of M1 receptors causes increased contraction of the GIT muscles. Whereas these anticholinergic drugs, that is the reason they exert, or as we can say they antagonize, that is the action of decreased contraction of this vascular smooth muscle tone can be observed, and it also causes the relaxation of the visceral muscles. The walls of the visceral muscles are relaxed. Sometimes it also causes, or as we can say, the gastric emptying time will be prolonged. So the emptying of the gastric contents which are present in the gastric or as abdominal cavity, in order to empty the gastric contents, the time will be more, or we can say it leads to constipation. So the gastric contents are not eliminated or emptied out of the stomach, then it leads to a condition called constipation, which is one of the major side effects of these anticholinergic drugs. And if it is given in overdose, so if the overdose, or as we can say if it is given in excessive dose, then it shows we can say it shows the diarrheal effect. So these antimuscarinic drugs are also dose dependent. So if we give in excessive dose, it causes parasympathetic mimetic activity, as well as if we give in particular dose, then it shows anti-muscarinic activity or parasympatholytic activity. So this spasmolytic activity is also observed. We can see this spasm, vascular spasm can also be altered because of fewer antimuscarinic drugs. What are the effects of these drugs in genitourinary tract? So what happens in the urinary system because of this drug? So here the vascular smooth muscle relaxation, the relaxation of the smooth muscles takes place because of this what we can say the parasympatholytic activity. So here, because of the antimuscarinic drugs, the vascular smooth muscle which is present in the urinary bladder will be relaxed, and thereby the voiding of the urinary bladder will be slowed, or else we can say the emptying of the urinary bladder will be slowed, or else the urine retention takes place in the urinary bladder. So and it is also useful in the treatment of spasm which is produced by the inflammatory condition. So because of the inflammatory or else the neurological disturbances or else the neurological conditions or inflammatory conditions that leads to the spasm of that particular organ, so these antimuscarinic effects can be treated because of the spasm which is produced by these inflammatory as well as neurological disturbances which are occurred. What are the we can say what are the effects on sweat glands? So even the sweat gland secretions can be reduced because of these antimuscarinic effects. If the sweating is not taking place properly, then the temperature inside the body will be increased. We can say the thermoregulation of the body can be altered because of these antimuscarinic drugs, and in adult the body temperature will increase with larger doses. So here if it is given in larger doses, as these sweat gland secretions are reduced, then because of that, as sweating won't take place, then the temperature inside the body will be reduced. So in adults, this condition can be observed at higher doses. But in infants, even the atropine at low doses can cause fever. Let us see the individual drugs. The first drug is atropine. So what are the actions of these atropine? So what are, or else we can say what happens because of the cholinergic blockade because of the atropine. First thing is like it causes decreased cyclic AMP levels, thereby leading to bronchospasm and decreased mast cellular degranulation. So what does this mean? So here this cyclic AMP is one of the most important chemical mediator which is causing contraction of the smooth muscle. So here if the cyclic AMP levels are decreased, contraction and relaxation of the smooth muscle can be altered because of the cyclic AMP. So here if the cyclic AMP levels are decreased, it shows decreased bronchospasm. So because if the bronchospasm is decreased, and thereby not only apart from bronchospasm, it also shows mast cell degranulation. So here the mast cells, or else we can say the release of the chemical mediators from these mast cells can be altered because of atropine, and it may also potentiate beta-2 receptor sympathomimetic activity. So if atropine, or else we can say the antimuscarinic drugs are given in combination with beta-2 receptor agonist, then it shows synergistic effect, or else we can say the beta-2 receptor agonist activity is potentiated because of these antimuscarinic drugs, and it is also helpful to treat in rhinitis. So rhinitis is one of the eye disorder where we can say the watery eyes are observed. And the dose of this atropine is mostly recommended to give in aerosol form. So aerosol is one of the, we can say it is the drug is given through in the form of air, or else we can say the drug is given in the form of air droplets. So the dose is almost 1 mg or 1%. Here we can see the mechanism of action of atropine. Here the acetyl coenzyme A plus choline. When acetyl coenzyme A and choline are binding together, it forms acetylcholine. And acetylcholine is, we can say it is metabolized by the enzyme called as acetylcholinesterase. And when acetylcholine is releasing, it binds to the muscarinic as well as nicotinic receptors. So here the atropine, it acts on these receptors, or else we can say the atropine is blocking the binding of acetylcholine towards the receptors, thereby it is exerting antimuscarinic activity. Let us see the pharmacokinetics. So what are the pharmacokinetics of these drugs? So atropine, it is the atropine absorption mostly takes place in the gut wall as well as conjunctival membrane. So the atropine, when administered, major absorption takes place in the gut, and even the absorption takes place in the conjunctiva of eye also. And scopolamine is mostly absorbed through skin, because the scopolamine is mostly formulated in the form of transdermal patches. So here if we take the scopolamine and patch and you just apply it to the skin, the drug penetrates to the skin layers, and thereby the drug is reaching the systemic circulation. And it also the metabolism of these antimuscarinic drugs takes place in the liver, but the metabolism is not complete. So there will be partial metabolism of these drugs, and these drugs are eliminated through urine, where as well as the half-life of these drugs are about 4 hours. What are the clinical uses of atropine? So this clinical use, the atropine is mostly recommended to give in anesthesia, anticholinesterase poisoning. So anticholinesterase poisoning, if the poisoning occurs because of this anticholinesterase, then that can be antagonized because of the atropine, as it prevents the binding of acetylcholine, or else we can say it prevents the acetylcholinesterase enzyme, thereby it is preventing its poisoning, and it also used to treat bradycardia and in antispasmodic conditions of gastrointestinal tract. What are the adverse effects? So at the adverse effects of these atropine is urinary retention. So when given in large doses, it causes retention of the urine, and it causes xerostomia. So xerostomia is a condition where it causes dry mouth, where the salivary secretions are reduced, and thereby it causes dry mouth, and it causes blurred vision. The other drug is ipratropium bromide, and the brand name of this drug is about Atrovent. I mean, it is marketed as Atrovent. So the ipratropium bromide, it almost shows the pharmacological actions of atropine. As I told you, atropine is a prototype drug. So it is as it is the other drugs, whatever the other antimuscarinic drugs are there, that mimic the actions of atropine. So this ipratropium bromide has the almost all side effects of atropine, but it has less all all the effects of atropine, but it has lesser side effects when compared to atropine. And this is given in the form of nebulizer. The atropine is given in the form of aerosol. This is given in nebulizer. So nebulizer is also one of the formulation where the drug is given through air droplets, or else we can say it is given through respiratory tract. And it is often showing the sympathomimetic activity. So in particular doses it shows parasympatholytic activity, but in some doses it may show sympathomimetic action also. And that is the reason it is very effective in coronary obstructive pulmonary disorder. The other antimuscarinic drug is tiotropium bromide, which is marketed as Pyriva. So this drug also has almost the same actions of ipratropium bromide, that is Atrovent, but as this drug is having longer T half, then that is the reason it is recommended to give only once a day. And it is also very good, or else we can say it is very effective to treat COPD. The other drug is glycopyrrolate, which is marketed as Robinol. So this drug is also having the pharmacological action similar to atropine as well as Atrovent. But here the peculiar characteristic feature of this glycopyrrolate is that it shows antacid effect. So or else we can say this is the anticholinergic drug which is used as an antacid. So in order to decrease the gastric acid secretions, as we discussed that antimuscarinic drugs will decrease the gastrointestinal secretions. So that is the reason this glycopyrrolate, it will reduce the gastric acid secretion, and thereby it is showing antacid effect. And it is also formulated in the form of nebulizer at the dose of 1 mg. Here we can see the tabular format of the drug as well as its clinical use. The scopolamine, it is mainly used in motion sickness. Ipratropium bromide, it is recommended to give in asthma and bronchitis. And tropicamide as well as cyclopentolate, they are used, or else we can say they are mostly they are used to produce mydriasis and cycloplagia in diagnostics. So they are used as a diagnostic agents in mydriasis as well as cycloplagia. And pyranzapine is used in peptic ulcer. Not only pyranzapine, glycopyrrolate is also used to decrease gastric acid secretion. And the drugs like homatropin and tropicamide are used in mydriatics. Hyoscine butyl bromide and oxyphenonium are used in GI spasmolytics. Pyranzapine is used in peptic ulcer. Ipratropium and tiotropium are used in asthma. Flavoxate, oxybutynin and trospium are used in diuresis, as well as benzotropin and piperidine and trihexyphenidyl are used in Parkinsonism. So the classification is based on the action also. So apart from the anticholinergic actions, they are having other actions also. See here the drug as well as clinical use, in which disease they are used is tabulated. The adverse effects. The most common adverse effects of any anticholinergic, or else we can say any antimuscarinic drug, is dry mouth, blurred vision, constipation, decreased secretions, or else we can say decreased glandular secretions in the body. It causes mydriasis, tachycardia, dry eye, hot and flushed skin. Because of the excessive release of the chemical mediators in the body, it causes hot and flushed skin, increased body temperature, hallucinations, depression, and in severe conditions it may lead to coma and death also. Let us see the anti-nicotinic drugs. So the anti-nicotinic drugs are further classified as ganglionic blockers and neuromuscular blockers. So why this classification is based on? So the nicotinic receptors are of two types, NN and NM. So what are these? So the subscript indicates the location of these nicotinic receptors. So NN indicates that the nicotinic receptors at the neuromuscular junction, as well as NM are the nicotinic receptors which are present at the muscular junction. So here the ganglionic blockers are the blockers which block the nicotinic receptor action which are present in the ganglia, and neuromuscular blocking agents are the drugs which block the action of these nicotinic receptors at the neuromuscular junction. So the drug which come under this ganglionic blockers are mecamylamine, nicotine, hexamethamine and pempidine. And neuromuscular blockers include suxamethonium, decamethonium, atracurium, vecuronium, tubocurarine, pancuronium and doxacurium. So let us see the individual drugs. So the ganglionic blockers or nicotine. So nicotine is one of the drug which block, or else we can say which block the acetylcholine to bind to the nicotinic receptors and exert its actions. So here this nicotine is mainly formulated in the form of patches, gums, lozenges, as well as the other formulations also. We can say the patches of nicotine are formulated. The patches we just have to apply it on the skin, and the gums which when chew the nicotine is entering into the body, and lozenges. So these are one of the formulations where nicotinamide is available. Nicotine is available in the market. So this nicotine, it aids to help in the stomach. If a person is a chain smoker, or we can say if a person is having the habit of smoking on frequent basis, then this nicotine is best recommended for that patient. And it also depolarizes how the mechanism of action is taking place is that it depolarizes autonomic ganglia. So here we said that ganglionic blocker. So there are autonomic ganglia which are present at the nerve endings. So here the nicotinic receptors which are present at the junction of these ganglia, the action of these nicotinic receptors are inhibited. Thereby it is causing paralysis of the ganglia. Thereby the actions, or we can say the conduction of impulses cannot take place to that nerve endings. This nicotine, when it is taken into the body, it shows increased blood pressure and increased heart rate. So because of this increased blood pressure and heart rate, it causes increased peristalsis and secretions also. So as this is an anti-nicotinic drug, these show the effects of increased action. So if we see muscarinic drugs, anti-muscarinic drugs, they causes decreased glandular secretions and decreased heart rate and all. But if we see anti-nicotinic drugs, they exert the action of increased blood pressure, heart rate, which are quite opposite to that of anti-muscarinic drugs. So even the effects which are shown by these receptors depends on the location as well as type of receptors on which the acetylcholine is acting into. And at higher doses, if the doses exceed than its normal, then it causes decreased blood pressure because of the ganglionic blockade. So if the blockade or ganglia blockade takes place for a longer period of time, then there occurs decreased blood pressure. And here, because of the decreased excessive ganglionic blockade, it may lead to the blood decreased secretion or else with decreased activity of GI tract, leading to seizing of the, or else we can say the effect of the GI tract is reduced. Here the mechanism of action, as I told you, the mechanism of action is nothing but the blockage of the nicotinic receptors which are present at the ganglia. So here we have how does this take place? So here these nicotinic receptors are ion channel receptors. So here at the autonomic ganglia, these nicotinic receptors, they won't allow the entry of ions to pass through them. So if calcium or sodium which passes through the neuronic ganglia, it causes depolarization of the particular neurons or membrane. So if depolarization takes place, then it shows the muscarinic or nicotinic effects. So in order to antagonize these effects, when the ganglionic blockade takes place, then it shows the blockade of the entry of ion channels into the nerve endings also. And these drugs are rarely used, or else we can say these drugs are having less therapeutic effect. That is the reason they are only used in the tools of experimental pharmacology. So here in the initial stages, or else we can say in the experiments which are conducted in the pharmacology, these drugs are mostly recommended rather than the clinical effect. The other drug is trimetaphan. So trimetaphan is a drug which blocks the nicotinic receptors, and it is an ultra short acting ganglionic blocker because the action, or else we can say the duration of this trimetaphan is very short. It's only for few minutes. That is the reason it is an ultra short acting drug. But this trimetaphan, it is sometimes, or else we can say it is occasionally used in hypotension condition to control the hypotension conditions, and in hypertensive emergency conditions, this drug is used clinically. Let us see the other class of drugs, neuromuscular blockers. So these neuromuscular blockers, what do? They block the action of nicotinic receptors which are present in the neuromuscular junction. So this is a junction which is present between the two neurons where the release of the acetylcholine from one neuron ending is altered. So from one neuron ending the acetylcholine is released, and to the other neuron ending the acetylcholine binding takes place. So this mechanism is altered, or as we can say the mechanism is blocked because of this neuromuscular blockers. And these neuromuscular blockers, we can say they are the structural analogs of acetylcholine. Why? Because if they structurally mimic the acetylcholine, then only they can bind to the receptors. So they don't allow the acetylcholine to bind to the nicotinic receptors, and that is the reason they show anti-nicotinic actions. And here we can see these neuromuscular blocking agents are also of two categories, that is antagonistic, or else we can say these are of two types, depolarizing and non-depolarizing. So here the depolarizing drugs act as agonists, as well as non-depolarizing drugs act as antagonists. So here we can see the mechanism of action. Here the neuromuscular junctions at the these nicotinic receptors are of ion channel based. So here the ion channel, or as any ion channel receptor, undergoes three stages, that is inactive form, active form and closed form. So here if they are in inactive form, then the we can say the block, or else we can say the clamp which is present in the ion channel is closed. So here when it is closed, it won't allow the entry of calcium ions to pass through it. So that is the reason it is stayed in inactive form. And when it is converting it into active form, the knob which is there, it is getting opened, and thereby the entry of sodium takes place. And here in the closed form, the channel completely closes and it won't allow, or else we can say it is in the resting state. So in all these conditions, if the channel is when the channel is in open state, only the entry of electrolytes takes place. So here this neuromuscular blockers, they act on the conversion of these inactive forms to open form. So if it is not converting it, if the channel is not present in the open state, then the entry of electrolytes won't take place. So this is how the neuromuscular blocking agents are blocking the action of nicotinic receptors. Let us see the pharmacological actions. So the pharmacological actions of these neuromuscular blocking agents are mostly they causes contracting of the face and neck muscles. So we can say the face and the muscles which are present in the face and neck are rapidly contracted. So because of that, sometimes it may lead to paralysis. So because of the paralysis, first the face and neck muscles get rapidly contracted, and apart from that, after that the trunk muscles as well as limb muscles are contracted. Because of this excessive contraction, after some time it may lead to paralysis of that particular organs. And once the limb as well as fingers, or as we can say the limb and trunk muscles are excessively contracted, then lastly the diaphragm muscles are contracted. There is a sequence: first face muscles, then neck muscles, then trunk, limb as well as diaphragm muscles. So all these muscles are getting rapidly contracted because of this neuromuscular blocking agents. So that is the reason they are not clinically preferred. The drugs like tuberculorin, mivacurium, atracurium, these drugs, they release histamine. So the histamine is a chemical mediator which is released from the mast cells. So when histamine is released in excessive amount, it causes hypersensitivity reactions, or else we can say it causes flushing and redness of the skin. And it also causes reducing the blood pressure also, and in and it also causes bronchoconstriction effect. And on CNS, so what are the pharmacological actions on CNS? So mostly the central nervous system activity, or else we can say the effects on the CNS are not mostly observed, but in some conditions the effects can be observed only if the drug is administered through IV route. So if any drug which is administered through IV route, it shows only mild central nervous system effects. And the drug called D-tubocurarine, DTC is nothing but D-tubocurarine, it produces the blockade it produces the fall in the blood pressure. So this is one of the characteristic features of neuromuscular blocking agents. Any neuromuscular blocking agent will reduce blood pressure. So this DTC, D-tubocurarine, it is reducing blood pressure by some mechanism. So what is the mechanism? if there is any ganglionic blockade, if there is any histamine release, or else if there is any decreased venous return, or else we can say the venous supply is decreased. So in all these conditions, this tubocurarine will causes fall in blood pressure. What are the therapeutic uses of these neuromuscular blocking agents? So these neuromuscular blocking agents are mostly preferred, or as we can say they have less therapeutic uses, but sometimes they are preferred to give prior to surgery as they cause relaxation of the smooth muscles. So in prior to surgery, in order to cause smooth muscle relaxation, these drugs are given as an adjuvants, and they are used to facilitate incubation as well as during the orthopedic surgery. So in these conditions, these drugs are used clinically. The other drugs like mivacurium. So mivacurium is one of the drug which is having a rapid onset of action. In the sense, once administered, it exerts its actions, as well as the recovery, or else we can say the recovery from the drug is also rapid. And this is also, any neuromuscular blocking drug is given prior to in surgical procedures. And the other drug is cis-atracurium. So this atracurium is of two forms, cis form and trans form. So the cis form is clinically used when compared to the trans form, and this cis form is used in mechanical ventilation of critically ill patients. So if a person is suffering from, or else we can say, in order to provide the mechanical ventilation to the persons, then this atracurium is preferred. And rocuronium. So this rocuronium is also one of the neuromuscular blocking agent which is having a rapid onset of action, and this is also useful in tracheal incubation as well as the persons who are suffering with gastric disturbances. Let us see the pharmacokinetics of these drugs. So what happens? So mostly the drugs are short acting drugs. If we see rocuronium, mivacurium, these are short acting drugs. So that is the reason they are rapidly absorbed in the body, and these drugs are mostly recommended to give in IV route rather than oral route or subcutaneous route. Here if we see there are tertiary amines and quaternary amines. We have discussed in the classification. So these tertiary amines and quaternary amines, they are when given in oral dose, they are very ineffective, or else we can say the effect of these tertiary or quaternary amines when given orally is very effective, because these amines which when given into the body, they undergo the metabolism at rapid action, or else we can say they undergo metabolism rapidly. So that is the reason these drugs become ineffective when they are administered orally. That is the reason they are recommended to give in IV route. As these drugs are hydrophilic in nature, that is the reason they cannot penetrate through the membranes. And even as they are hydrophilic in nature, they even can't cross blood-brain barrier. So here, how the distribution of these muscles is taking place, or else we can say the redistribution of these drugs is taking place. For example, if we take tubocurarine, pancuronium, mivacurium, these are administered, these when administered, they are excreted in the urine unchanged itself. I mean, they are not forming any metabolites, they are not undergoing metabolism at all. So these drugs are excreted in the urine as such. So because of that, the redistribution of the drug, if it is converting into metabolite, the drug is redistributed and thereby the drug action is retained. But if the drug is excreted in the urine as such and metabolism is not occurring, then the redistribution of drug won't take place, thereby the action, or else we can say the action which is produced by the drug is terminated. And the atracurium, it is degraded spontaneously in plasma non-enzymatically. So here it is a Hoffman degradation. So Hoffman degradation is one of the chemical reaction where the degradation occurs enzymatically, or else we can say because of the action of the enzymes which are present in the plasma, this reaction is taking place. So the atracurium is one of the drug which is undergoing this Hoffman degradation. This atracurium is also having one of the characteristic feature. All the neuromuscular blocking agents have the characteristic feature to release the histamine. But the histamine which is released by this atracurium because of that it is getting metabolized and it is forming a compound called as laudanocin. So this is the metabolic compound which is formed because of the metabolism of atracurium, and that is leading to seizures. So this atracurium, if it undergoes metabolism, then it produces the metabolite intermediate which is producing seizures in the body, and that is the reason this atracurium is produced, or as we can say it is replaced in the cis form. So in this cis form, the metabolism of this atracurium is prevented, and thereby the intermediate called laudanocin is not formed. And the other drugs like vecuronium and rocuronium, they are undergoing metabolism in the liver by a process called deacetylation. So the acetyl group which is present in these drugs are removed, and thereby the metabolism takes place. What are the drug interactions? So, or else we can say in which conditions these drugs are to be contraindicated. So, these anti-nicotinic drugs or neuromuscular blocking agents have the drug interactions with anesthesia, especially halothane only, and antibiotics, local anesthetics, anti-arrhythmic drugs, calcium channel blockers, and other neuromuscular blocking drugs, neostigmine and peridostigmine. So these anti-nicotinic drugs should be contraindicated in these conditions.